All right, hello everyone. My name is Karina McKenzie and I'm the Marketing Manager for Surgical Notes. I'd like to thank all of you for taking the time out of your schedules today to attend today's webinar. Now, before we begin, I just want to cover a few items. Now, because of the size of the group that we have here on the line, we do have everyone on mute to reduce any background noise. So if you have any questions, anytime during the webinar, we do encourage you to type those into the question box that you should see there on your GoToWebinar control panel. And at the end of the presentation, we're going to answer those questions for you. Secondly, we are recording this webinar, and I'm going to email the recording along with the slides to everyone by the end of the week. Now, Chuck Meisel, he's Surgical Notes VP of Sales, and he's going to be moderating the webinar today. So at this time, I'll turn the presentation over to Chuck.
All right. Thank you very much, Karina. And good morning to those of you on the West Coast, and good afternoon to everybody else in the country. Before I get started and introduce Matt and Angela to you, kind of how this webinar and the topic came about is you can have an amazing physician team. You can have tremendous clinical staff, really good leadership at the surgery center, everything positive. But if you don't have good managed care contracts, you're missing out. And that's where this topic tied to what you can do, and the do's and the don'ts kind of came from in our conversation with both Matt and Angela. So quick introduction, Matt Kilton. Matt's a highly experienced healthcare executive with more than 20 years leading and advising healthcare delivery organizations. He has extensive knowledge in ASC reimbursement, coupled with his background of managing and working closely with the healthcare providers, enable him to win the confidence of ASC leaders, as well as the ancillary providers, the payers, etc. Before joining ECG, he was principal and chief operating officer at Evia Health. And in this capacity, he negotiated substantially, this is the key part, profitable managed care contracts for ASCs, physicians, and group practices that own ASCs. He's helped a number of new ASCs prepare for opening by negotiating reimbursement agreements that position them for both immediate but also long-term success. And he's also helped centers that have struggled because they did not have well-managed and well-negotiated managed care contracts that were hurting the center. Angela Mattioda is the Vice President of Revenue Cycle Management Services for Surgical Notes. Angela's got over 18 years within the ASC RCM space, great background in ASC business analytics, managed care contracting, and team management, as I can well attest to. She helps our customers reduce their AR and maximize their reimbursement. Her experience across multiple billing platforms and in-depth understanding of the different challenges within those platforms helps us with managed care carriers, both in and out of network claims. And her bottom line is, and her team is to help surgery centers optimize their revenue and maintain financial performance. Super passionate, as I know everyone will pick up from this webinar. So if Angela, Karina, if you could go ahead and start with the do's and the don'ts. Number one, in the don't, this is kind of a no-brainer, but bottom line is don't accept that first offer. Don't get impatient, and that the payers intentionally go slowly. Matt, give us your background tied to what you've seen and working with, particularly with centers that are de novo, and it's their first go around with negotiating with payers.
Thanks, Chuck, and thanks for having me. You know, the challenge for de novo centers really lies in not having a clear awareness of how commercial managed care contracts work for surgery centers. Each payer is a little different. Their methodologies are different, and it's not uncommon for payers to intentionally progress at a slow pace, generally because the payer doesn't necessarily need a surgery center in their network, and so it's advantageous from the payer perspective to to go slowly. So they'll start with a low ball or a quote unquote market rate, or we've even seen below market to see if a facility is eager or needs to contract. And payers certainly recognize that new centers have debt that they're taking on and costs that they're taking on, and that creates an added pressure for a new center to open. So they, as this slide indicates, they will intentionally go slow, and they'll do their best to essentially wear you out or wait you out.
And Angela, your thoughts?
Well, I have personally seen firsthand some contracts that have been signed by clients where they have accepted the first offer. And so I've seen the negative impact of not being patient and negotiating that contract and taking your time. So you definitely want to take your time and negotiate, because the likelihood of the fees increasing as you negotiate are very high to some extent. And it depends on the payer, of course, but you will likely always get more when you negotiate and not accept that first offer.
Oh, yeah. I think it was Matt said this the other day, was negotiating 101, never start with your best offer. So it's, but if as a second follow up to this is, you're the new center, you've got all this debt, they came to you, you don't get a reply. If you had to accept this first offer, can you try and mitigate that damage perhaps by making it for only 1 year? Or Matt, or those contracts always have an evergreen clause, et cetera? What are your thoughts there?
Well, Chuck, yes to both. Generally, payer contracts have evergreen clauses, but you can attempt to limit the term, and that's one of the negotiating points. I mean, essentially everything inside the body of that agreement is negotiable, rates and terms and lengths of time, and so that would be one step to try to mitigate the impact of an undervalued contract. And sometimes payers will use the perspective that, not knowing much about the center or what the center will do, they're hesitant to really broaden the contracting negotiation or the rate negotiation. So they'd like to see some volume, and so often a center starts out a network, and that volume helps to paint the picture for the center. But the risk for the center, for the payer, pardon me, but the risk for the center is performing services that are undervalued sends a concerning message. And I know we'll talk about that a little bit more in the future slide.
Good point. Okay, well, thank you. Karina, number 2, please. Don't accept discounts off of existing federal or state fee schedules, such as Medicare, Medicaid, TRICARE, workers' comp, auto, PIP rate, etc. Angela, when you've seen this done, what has been the outcome for the centers down the road?
Typically, when you sign a commercial contract, there might be other products that are involved, like the Medicare product, Medicaid, work comp, and auto. What you want to really watch for is any discounts on those particular products. Sometimes we'll see an additional 2% discount on Medicare. Work comp, the most common is a 10% discount for work comp and auto. Because 10% is fairly common, if it ever goes beyond that 10% discount, and I've seen discounts up to 70% off of the fee schedule, every percent you're losing, because if you sign that contract with that product in there, you are losing based off of a fee schedule that you have a right to collect on those funds. So you definitely want to be very aware of these products and make sure Medicare, as long as you're getting paid 100% of Medicare for the Medicare product, any percentage over that, of course, is a win. But as long as you're coming up straight with the Medicare product, and limit the discounts that you allow on the work comp and auto.
And the reality is, you just don't know that initially unless you're experienced with this. Is that kind of your observation, Matt?
Yeah, over and over you'll be negotiating a contract. Let's say Aetna has offered you a commercial rate. You're negotiating that contract, and you get to the end, and suddenly the contract arrives with 3 or 4 additional addendums that include a worker comp page and a Medicare page and a PIP page and even a rental network. And it's not listed on here, but another common approach is to rent access to your contract throughout a broader network, like a First Health or organizations that are national repricers. And the payers don't necessarily disclose that in the negotiation. So it's important, Chuck, to ask that question early on. In addition to the commercial products we're discussing, are there any other products that will be included in the final contract documents that we should discuss now or begin the conversation around now? And if you start that early, many states have rules that say a payer can't exclude you from a contract if you choose not to participate in all products. So maybe at the end you say, listen, we're happy to do the commercial product and the Medicare product, but we're not going to participate in the auto product or the worker comp product. So that's something you can mitigate if you're in a state that allows that. And again, really that rental network is the concern, because those are commercial contracts going out to other entities that you may not even be aware you have potential patients flowing through.
Exactly. All right. Well stated. Next slide, Karina. Number 3, don't accept all-inclusive rates to include provider, anesthesia, and other ancillary services that may be or they may want you to include. And Matt, when you expound upon this, what are the risks if to doing something like this? Because it sounds very positive.
Well, we see this more and more, and sometimes we call these all-inclusive rates a case rate. Sometimes we call them a bundle. I think it's important to distinguish between those two. A bundle is generally considering pre and post-op services in addition to day of surgery. So it may include a new patient visit, it may include radiology, it may include 90 days to post-op care. And the case rate is really intended to be services on the day of. So surgical facility services, maybe implant, maybe anesthesia. There are some benefits to this. We have seen payers offer a greater value in a bundle, or a case rate, but the risks also are significant. I mean, the facility becomes the bank, has to administer the claims, has to ensure that those other providers, anesthesia and other providers, are not sending a bill to the payer. If there are sales tax implications in any given, or revenue tax implications in any state, the ASC may be paying taxes on those receipts and then paying these third parties for their services after tax. And there's also the reality that you now find yourself in a position of having to negotiate with that anesthesiology group or that pathology group or radiology group or whoever that provider is to arrive at a rate that makes sense. Right. So it can, for one payer, that could create some challenges or contention. And so we generally try to exclude those other providers, let those providers contract directly with the plan if it makes sense, and not get ourselves in between those issues.
Angela.
So on top of what Matt said, the case rates I think are helpful. The case rates that you can carve out and what you're going to get paid for that procedure. It might be inclusive with the implant or without, but when you're responsible for getting paid, depositing that money, paying taxes, you have to disperse it. I've seen it go as far as not only including provider and anesthesia, but physical therapy as well. And so when you are doing a bundled payment and responsible for disbursement, you really need to do your homework and dig down into those disbursements and determine whether or not your facility is going to get paid, with the tax implications also involved, what that payment will be, as well as the provider and other vendors that might be that you're dispersing those funds to ensure that all areas are acceptable in that rate.
Good point. And Matt, is kind of a follow-up there. If a payer, is this typically driven by the payer? And if the payer is encouraging this, does a payer typically commit to increased volume? And in your experience, have they been able to deliver on that volume?
You know, I've seen the driver behind this be both providers and payers. From the payer perspective, it's less about volume, it's more about cost control. Again, to pick on a payer, we've seen Aetna apply rates to contracts, and inside the body of the contract, buried somewhere deep on the 724th page, is a statement that says you're going to pay the anesthesiologists. And so that's not really brought out in the conversation. You have to see it to identify it, and then try to negotiate that out. And conversely, when a provider or group is interested in this case rate, they're often looking for volume to be part of the equation. So their goal would be, if we accept this, payer, we'll work in cooperation to try and deliver volume to this hopefully lower cost in the long run option. And you know, at the end of the day, I don't know how much directionality a payer can apply. You know, payers don't refer patients directly. Surgeons and primary care physicians refer, but a payer can create benefit designs that encourage it, right? So maybe my health insurance says if I elect to go to a local organization that has something like this, I'll save on my co-insurance or deductible. So there are some directionalities, but it's more provider driven.
Okay, excellent. Number 4, don't perform cases that lose money with the intent on renegotiating those rates later. It's really hard to make up on volume. Angela, I know you've seen this a couple instances. Could you elaborate a little bit, please?
Well, this really has to do with when you're adding certain specialties or procedures that might not be covered, and you're taking a loss on those. So again, it's really important to know ahead of time, when you're negotiating the contract, not only what procedures you're currently doing, but what providers or specialties are you looking to incorporate into your center. To keep that in mind, just because you aren't doing ortho today when you're negotiating the contract doesn't mean that you can't negotiate orthopedic rates in that contract. And so you aren't going to be able to renegotiate your contract during the term. You're going to have to wait until the end of that term to renegotiate it. So if you start performing those cases that aren't covered in that contract, it's like a conversation I had with Matt before, then you are ultimately indicating to that payer that you're okay with taking that loss, that you're okay with, taking the lower amount or it not being covered. And they might question that down the line when you're renegotiating it and play hardball when you're trying to get those rates included.
Because you've already told them that, hey, we'll do it for that.
But I've been doing it for this, and if you've been doing it for 6 months or for a year, then and if you haven't been, it's catch-22. Why are you doing it if you aren't profiting off of those cases? So they will be less inclined to negotiate with you for the optimal rates.
So Matt, if somebody's done this and they've accepted a rate and then they lose money on certain specialties, perhaps, what's the strategy when they do get the opportunity to renegotiate?
Well, you hope you never experience this, right? But generally, when it happens, it's driven by a desire for ease and efficiency. So it's maybe a surgeon comes in and says, listen, I just need to do this one case. Can we just please get a contract? Or we have so little volume, let's not worry about it, or let's not waste our time because everything else we do is profitable. And as Angela pointed out, you've messaged the payer it doesn't work. We can afford it, pardon me. You've messaged these rates are okay. And unfortunately, you're also messaging all your other payers through coordination of benefits. So my surgery center does an ACL for half of what it does for other payers, and then those other payers are the secondary claim, and I just told those other payers, hey, I can afford to do an ACL at half the price. So ideally, if you find yourself in this situation, it's best to start by communicating with the surgeon to explain the challenge it creates and the impact it's having overall. Most of the time I found surgeons recognize that saving a little bit of time in a manner that's going to have long-term negative effects probably isn't worth it. And then, communicate to the payer would be the next step to outline that these have been happening and we're going to stop. We're going to stop doing these cases because we've after some more detailed analysis determined that we can't afford to. And I would advise maybe determine what those cases cost back at the hospital if possible to try to paint the picture, paint a better picture for the payer that you've been saving the payer all this money and that's great, but it needs to make sense for the center. It has to be a reasonable rate and it has to be an affordable rate, and at present it's not, and want to proceed toward correction.
And it's the same, it's the same as when you're negotiating out a network on the back end. If you're willing to accept a lower rate, then you're setting that benchmark with those third-party pricers, and they know that in their systems. And so when you go to negotiate again, and I've dealt with this a lot when we have new clients that come on with surgical notes, that the benchmarks were low, and we have to work really hard to ease those benchmarks back up because the reps come back to us and say, look, we've been paying this rate for the last year or two. You guys have been signing off on it. We say, well, that wasn't us signing off on it. There's a new sheriff in town. That's not going to be acceptable.
Excellent. Because I know every administrator out there time or another is having to deal with one of the physician partners who says, hey, I know we're going to lose money in this case, but let me get it done here. And so hopefully this will help them down the road not have that happen. Number 5, don't accept lower rates from smaller payers just to get the deal done. Coordination of benefits between payers results in those lower rates being communicated to bigger payers. And Matt, you kind of referenced that tied to secondary. And I'm sure there's other examples tied to consolidation in the market, et cetera. What are your thoughts here?
Well, right. I mean, and if our audience has been playing, word bingo on the don'ts and just hit number 5 and yelled out bingo, I'm sorry, but yeah, this is a critical one. It's easier to not spend a lot of time negotiating with a small payer because, well, they just, we're only going to see a few cases a month or a year out of this payer, and it's just not, it takes just as long to work with the small payer as it does the large payer. There's the speed and the lack of efficiency don't change with the volume the payer is going to offer the center. And so we've all done it. It's gosh, it's just easier to get this done and get it off my desk and move on to more important issues. But ultimately, it does message, as we just touched on, the fact that the center can take the number. I've got a client right now that's got a fantastic contract with a very, very large payer, and the small payers are getting better deals. And that large payer has come back to the table and said, we see through the COB what's happening. We recognize that we're not only delivering 10 times the volume of these other payers, but we're paying more, and that's not sustainable for us. And it's hard to argue with that logic. It's hard to say, well, no, you should still pay more, even though another commercial or national payer is getting a much better deal. And so it puts a center in a bad long-term position with its most important commercial payers to accept lower rates. And you touched on it, Chuck. There's still consolidation in the insurance industry. There's still payers being bought, and when a bigger payer buys a smaller payer, that larger payer now owns those contracts and owns those lower rates and can apply those to a broader book of business. So it's not as common as it used to be, but it's still happening, and it's worth paying attention to. Yeah,
and Angela, I'm sure with your experience, particularly in the California market, and I know there's a lot of payers, but there's also a plethora of other payers in that market. What have you seen tied to the damage done when you do this?
The same as Matt had mentioned. I think that it's a myth that if you do sign in a hurry just to get this out of the way with one of the smaller payers, that you'll make it up in volume. You are not going to get the volume referrals from the payer on those smaller payers that will make up for the loss and the harm that it can do with your bigger payers that you have a higher volume. It well outweighs the benefits of, doing 5 cases a month that are contracted at a low rate.
Excellent. At the beginning of the webinar, I should have alerted everybody because initially it was the 3 do's and 3 don'ts. And we got together and it got up as high as 20. I'm kidding. But we did come up with more than 3 and then whittled it down to 5. So that's why you're seeing 5 instead of the 3. And so now we'll transition over to the things that you've got to do. And the first one, very apparent, but it doesn't necessarily make it easy to do, particularly when you're the new administrator or you're coming into a new surgery center. Knowing your cost per case, your payer-specific volumes, market position, from a marketing perspective with your physician partners, and what's your value to the payer within that particular market? Are there a million other options out there? Angela, what if you were to again help somebody understand what they need to start with and what do they need to have at their fingertips before they begin the negotiating process with a payer, what would those be?
The first point on there, knowing your cost per case. So what are your high cost procedures that you're performing? You need to know how to proceed when you're negotiating those rates. So if you know that beforehand, you're going to have to know it when you're negotiating the contract. So having all of that laid out is going to be very, very important. Knowing your volumes, knowing your anticipated procedures or specialties that are going to be possibly coming down the line. All of those are important. So you want to make sure, if you don't know how to do the analysis, and it can get quite tricky. I mean, that is why there are companies like ECG or the RCM companies like Surgical Notes that can help do the analysis so that you can end up comparing it to maybe the previous 6 months or years worth of cases to see how you would come out after you get your first proposal. So doing that homework and knowing that information, pulling some of your invoices for those high cost cases, having that handy so that you can also give that to the representative as backup to support your high cost cases.
Right, excellent. Matt, when you look at market position, what do you think about?
Well, Chuck, I think in the doing your homework phase, market factors are critical, and none of the quotes I give in any of these things are my own. I plagiarize everything. And preparation creates separation. Preparing for a negotiation by understanding what your market looks like. What is the ASC or hospital environment in your area? Are you the only game in town, or are you one of many? Is the hospital the only hospital in the area? And maybe you've even got some intel on what the hospital is being reimbursed for the same services through EOBs that patients or surgeons have seen over time. But really understanding what it costs the payer to receive services in the market. And if your center is competing with other surgery centers for the same book of business or the same types of services, that's going to impact what the payer is offering or what the payer may allow. And so you'll have to create or identify other areas where you are unique. So are there services your center is doing that only your center can do, or you have equipment only available at your center? And we've even seen facilities, surgery centers that have equipment the hospitals don't. And so that separates them from the payer in the payer's eyes in some sense. And homework also includes things like understanding how does the payer's methodology work. When you've seen one, you've seen one. Each payer has a different reimbursement methodology for surgery centers. They're essentially customized, whereas the hospital and physician methodologies are more consistent across payers. And another thing you want to gather is just what are the questions you even ask a payer in the negotiation? What can the payer accommodate? What can't they accommodate? How are they going to handle implants and multiples and drugs and all kinds of other variables that go into the final result? And knowing the questions is half the battle. Payers won't offer flexibility unless they're asked, and knowing where that flexibility lies might help a center get to a number that makes sense, even when at the start it necessarily wouldn't make sense.
Excellent. The second do is request adequate reimbursement rates for your high cost cases. And Angela, you kind of referenced that there, but whether that's in the form of a carve out case rate or negotiating changes to specific groupers. Matt, what's been an example of a success where you've been able to do this, or where the initial proposal did not include this?
Yeah, I mean, probably the most common one we all see are just adding new services. So maybe over time, we're all pretty familiar with what a cataract will reimburse, or what a upper or lower endoscopy reimburse. But new services, cardiac services, total joints, spine, those are more recently introduced to surgery centers, and the payers may not yet have a real clear comprehension of what those services cost, or what a reasonable reimbursement is. They look to the Medicare list that may or may not be on the Medicare list yet. And oh, by the way, Medicare isn't always exactly 100% the best pricer of a cost of a service, because they're basing it on the volume of Medicare patients that have had that, and that may or may not be a surgery center service for Medicare patients. So, you're going to see this in the cardiac space, in the spine space, and really it requires understanding, as Angela pointed out a moment ago, what is your cost for the service? What high cost implants, what high cost equipment are you using? And then explaining that in a logical manner to the payer, and helping them reflect on what the true cost of the service is. And again, if the payer does not have a lot of experience with it, it might take time to bring them up to speed. It might require introducing a medical director to a surgeon to help explain a little bit more how the procedure will function, and what the requirements are, pre and post-op requirements, all those kinds of things. But we see time and again the value of sharing that information and taking the payer through that process, so the payer can truly understand. And it never hurts to pair with all of that information on your cost what the payer is paying today over at the hospital for that same service. They should know, but they don't always have a direct pipeline to pull that information out, and they may not know even which patients to research to identify that cost. So if you can provide that information to the payer and explain or show, every time this goes to the hospital, it costs $40,000. It costs us $20 to do it, and we need margin on top of that. So we're looking for 25. That's a great savings for the payer, 30-40% savings, and a great savings for the patient.
Good point. Especially tied to this is with the growth in the cardiac procedures and what was approved by Medicare. And then I would assume the assumption is that the commercial payers will follow suit. Angela, I know in your background you've seen plenty of experience where the high reimbursement cases, the high cost procedures, the reimbursement didn't come close to it.
Yes, it's not very uncommon, and you really, besides the high cost, you really want to zero in on your top performing procedures. A cataract is not a high cost case, but if you don't necessarily negotiate it and it's your top procedure, then you're looking at it falling into one of the lower groupers, and you could potentially be taking a loss. Coupled with the specialty lenses, you want to make sure that you have the ability to bill the patient with assigned ABN for those. And so you're not only basing it looking at Medicare, but you want to look at it compared to your other contracts that you have. You want to pay attention if you're using a robotic system that costs the center $2 million. That is something that the payers should be aware of. Low or no infection rate, the outcome, the patient satisfaction, any high cost equipment and robotics that are being used, all of that goes into play to support your high cost cases.
Outstanding. Do number 3, negotiate coverage for your implants at least 5% above cost. Angela, when you've seen centers that have not done this, what's been the impact of their business?
Well, it can be devastating. Implants, if you aren't using IPG as a vendor to supply your implants, then every implant is something that is out of pocket for the surgery center. So it can be detrimental. I always say that if you can get your implants covered at cost, I consider that a win. Anything over cost is excellent. And so you definitely, I see it at 5% over cost, 10% over cost, and I also see them completely carved out. So you definitely want to make sure that you're getting your implants covered. There are some large payers that it's a hard stop. And when it's a hard stop and they will not pay your implant separately, that's when you really need to get into the carve out and ensure that your cost is covered for those cases that they will not reimburse the implant separately.
Is the carve out done? Can the carve out be done later on, or is the carve out always done during the preliminary or the first negotiation of the contract? Angela?
It starts at the beginning.
Okay.
You know, it might come up down the line as well. You know, it might start with a grouper rate, and that grouper rate is low. You negotiate it, and it's still too low, so then you move to the carve out. You might have, you know, totals. You're never going to have those included in a grouper. Those are all total joints are always going to be part of a carve out code. So you start off slow, like the payers start off slow, and then you're going to progress as the rates start increasing so that you know where your cost is. That's part of doing your homework.
Matt, your experience?
Yeah, you know, Chuck, the implant question is probably the most difficult, and I would imagine there are members of our audience listening now saying, you know, I've tried this and I've been told by my local Blues payer or some other commercial payer that they simply don't cover implants. So how am I going to get cost plus if I can't even get cost? And that's a reality, and state by state, there are definitely pockets where we see implants are simply not covered. And as payers move towards a percent of Medicare as their methodology, a lot of them are including implants in that as well. But in markets where you can negotiate implants, this is critical, trying to get cost or cost plus. In markets where you can't, or payers that won't, the next step is frankly to look at those implant costs and account for them in your negotiation. So account for the cost of an endo button and a ligament and an ACL, or account for the anchors and screws and a shoulder repair, or account for the plates and screws and cages and bone putty and a cervical fusion, and know those costs, as Angela was pointing out earlier. Know those costs, so when you're at the negotiating table, maybe there's a rate you've established with other payers for the service without implants, where the implants are paid separately, and you take that rate and you add the implant cost, and now that's your rate for the payer that is going to bundle the implants, or assume that you're paying for the implants within their pricing. And I mean, I get it. Payers are saying, hey, we don't want the risk or the exposure to varying implant utilization, and we're not going to tell you how to practice medicine, physicians. You decide what you want to use, but it's financially going to impact you. And so there is some logic behind that implant not covered from the payer perspective, but it's unreasonable for the payer to assume that there's not going to be a cost associated with those, and that those costs aren't adequately covered. Because when the hospital bills them, they get a 3 and 4 times invoice cost charge, and those are generally covered in the HOPD setting. So you know, this is one where try if you can, and if you can't, there are other ways to achieve reimbursement for those services. But it goes back to our earlier points about understanding the costs and doing your homework.
And inquire if they will be open to utilizing a vendor like IPG.
Absolutely. Yep. Good point. Yep.
Number 4, negotiate annual increases into the contract at the beginning. What are your thoughts here, and when do you try to do this, Matt?
So, like we said earlier, Chuck, the payers are going to create evergreening contracts, and in a perfect world, you arrive at agreeable rates. The contract has a year or maybe 2 on it. Some terms go up to 3 years now. And in the payer's perfect world, you put it in a drawer and forget about it. And then 5 years down the line, you realize, well, I haven't seen any increase from United in 5 years. And so what we try to do more often than not is arrive at rates that are reasonable for the client, and then go back and request escalators, annual escalators. And again, it's just another point in the negotiation, but we don't like to necessarily start with that, because it creates a scenario where the payer might bring us to our optimal number over time, as opposed to getting us to that optimal number at the onset and then going up from there.
Yeah,
now, it can be a tool. If a payer says, listen, you're just asking too much, Matt, in the center, we're sorry that they're maybe below market, but we can't get them there in 1 year, then maybe the escalator is a way to get all parties to an agreement and spacing out those increases over a broader period of time. And I've seen that go 3, 4, 5 years in some instances where it took that long to get the rates where they needed to be, but at least there's a pathway to getting to market parity. But yeah, it's something we generally ask for towards the end of the negotiation, not on the front end. And we're looking for, COLA 2, 3, 4, 5%, somewhere in there, to make sure that the annual costs of the center is experiencing are covered.
Angela, I know you've had customers that have been on the same contract without annual increases, and then they finally get the opportunity to renegotiate the contract or begin to. And meanwhile, they've stayed flat, and they could have been increasing it anywhere from 2 to 4%. What are your thoughts tied to the due number 4?
Yeah, it physically hurts me when I see, I'm serious, it physically hurts when I see that a contract has not been negotiated in 5, 10, and I've seen them even longer. It is just a year-over-year loss of revenue. Seeing a contract have a COLA provision in it, which is the cost of living adjustment, is always a breath of fresh air, knowing that that's locked in for the next 2 or 3 years. Typically, some payers are excellent. Aetna, typically, for example, usually, you won't even need to ask. I find that they typically will include that COLA increase for a 2 to 3 year period. But like Matt said, best practice is to wait until the end, negotiate your rates first, and then address, the potential year-over-year annual increase, so they don't take that 2% increase that you're going to get after year 1 and take a hit on it, as with the original rates that you had agreed to. So you definitely want to address it on the end. Some payers will not put that COLA into their agreements, and that's okay too. And if that is the case, then you need to mark your calendar for the time when that contract is up for negotiation, so that you can make sure that you get that increase that you deserve.
Outstanding. Thank you. Number 5, or 2, is really understand the health system, your market, to ensure contract rates are market competitive and also reasonable. Angela, do you want to start us off here?
Sure. I think this comes into play when you're using an outside vendor, or when you have an RCM company that is negotiating your contracts. This is where they become really valuable, because they have all of their data that they can benchmark to ensure that you're getting a very competitive rate in your market. So when you're doing it just yourself in-house at a surgery center, it might be more difficult. You really can compare it to Medicare or your other contracts that you have. It might be a good idea to reach out to some contacts or to some other centers in the area, if you have contacts there, to get some insight onto what their rates are and how successful they've been in negotiating those rates as well.
No, it's a great point, because I think some of the state associations can also help, as well as I think even within ASCA, they've got a couple capabilities tied to understanding a national average, maybe regional, et cetera. Matt, what are your thoughts?
Yeah, it strikes me, Chuck, as the surgery center, especially one that isn't aligned with an RCM company like Surgical Notes, is really at a disadvantage in that they don't have any really market intelligence. Health systems have market intelligence. Certainly the payers have all kinds of market intelligence. Everybody kind of knows what the market looks like except the surgery center. So it's incumbent upon the surgery center to do its homework in the sense of understanding, as we talked about earlier, what the market is for these services. If the hospital's getting 50,000 for an ACL, that's a crazy number, but to make the point, taking 1,000 is not really a reasonable number for the surgery center. But we see the opposite. We see the hospital reimbursement for a service is lower than what a surgery center thinks is a reasonable ask. And it's not because the surgery centers are greedy or egregious. They're just not a basis for comparison. So we really strongly encourage organizations that are embarking upon this or who feel like they're ready to go it on their own, that they try to gather as much information about their region, their market, with respect to what the reimbursements are. Again, the health system, the hospital or the local system is the best benchmark because payers can't sell insurance without a hospital in the network.
Yep.
They don't always need a surgery center, so we like to base it on that hospital alternative. And generally, your surgeons have privileges at two places: your surgery center or the hospital. So it's at the end of the day, they're going to take the cases to one of the two, and if it's not your surgery center, it's that market hospital. So understanding what that cost looks like really positions the facility in its conversations with payers to have a good faith conversation as opposed to just kind of throwing numbers at the wall to see what sticks.
No, very, very good. And it's interesting because I think tied to this subject and what every center out there has been dealing with tied to COVID-19, the lower volume furloughing of employees, et cetera. I mean, really surviving through this period, putting in for the PPP, et cetera. Hopefully it's given some folks an opportunity to take a look at their contracts and really understand, all right, hey, take a look, how does this one align? Hey, who can I reach out to get some analysis completed, and which ones are coming up for renewal or renegotiation over the coming months or years. And thank you, everybody. I'm going to turn it back over to Karina, tied to questions from the audience, and I'm sure we've got a few.
Yes, thank you, Chuck. So we did get a few questions from the audience. I'll go through those. And of course, if you think of any more, type those into the questions box and I'll make sure to get to those. So the first question I saw come through here was, our center's Blue Cross Blue Shield agreement has 0 reimbursement for implants, and our renewal isn't for another 9 months. What do you recommend we do immediately? Angela, what do you think about this?
Well, I actually love Matt's take on this, who has dealt with this, and Matt might be better to speak to this, but it really is important to send in your letter that you are going to be ending the agreement so that they know they can take it more seriously, and that will open the door to negotiate new and better rates. Blue Cross is really difficult to get the implants included, but I see it happening. It depends on the state and what market you're in. I also see Blue Cross utilizing IPG, which might be another resource that you can bring up when you're renegotiating those rates with Blue Cross.
Yeah, and Matt, do you have anything to add to that?
Yeah, Angela iterated it very well. I mean, in a situation where you're 9 months out from renewal and not receiving adequate reimbursement for implants, you want to understand whether your state Blue Cross does allow them or there's the opportunity for them. Sometimes there is, sometimes there's not. In Michigan, no way. In Florida, absolutely, through IPG, like Angela noted. So that's a market by market specific question. I guess we don't know where this center is, but the point of communicating early to the payer, to Blue Cross, that there's a problem and it needs to be resolved is important. And Angela touched on it. We like to send a letter of non-renewal. Now, you notice we never use the word terminate or term. Term is a 4-letter word in the insurance industry. So a letter of non-renewal simply says our agreement's coming up in 9 months, and per section 6.2 of the agreement, we are not going to renew at the current rates, period. Below is our proposal to continue the relationship, and we look forward to a good faith negotiation, and included in that proposal might be coverage for implants. So you've satisfied the contract document by saying we're not renewing. You've clearly communicated to the payer your willingness to negotiate and have a good faith negotiation, and you've given them enough time to do it. Sending that letter 2 weeks out won't work. It's just not an inadequate amount of time to engage in that conversation. So communicate early. Don't allow the contract to renew. So send that non-renewal notice. Do not use the word term or terminate anywhere in the document. And maybe you finish that document with, our ability to get this done will ensure that we remain a committed partner to Blue Cross now and into the future. So show your willingness to work together and that you want to be there. But Blue Cross needs to resolve some of these payment issues.
Right. And if they come back and they are still standing firm in your renegotiations that the implants are covered, that's where it's important to have all your cost analysis done so that you can show them where you're taking a loss, because they don't necessarily, they obviously want to make money, and boy, do they. But they don't want you necessarily to take a huge loss, and they don't expect you to. So have your paperwork and your documentation ready so that you can show them where you are losing money on the cases that include the implants. And then that's where you would need to push to get those carved out so that your implant cost is covered in the carve out rate.
Great, thank you guys. Okay, next question I got here is, if I'm negotiating rates and they tell me they can't go any higher, what options do I have? Are they really maxed out? What are your thoughts there, Matt?
Well, there are situations where a payer will hit whatever a top end will be. I think what I want to understand in that scenario is, are we talking about rates unilaterally? Are we bumping into challenges maybe with for, let's say, groupers, and then are there other areas of opportunity that we haven't maxed out yet? So maybe we can't go any higher on the groupers, but we can talk about carve-outs, or maybe we can't go any higher on groupers and carve-outs, but we can talk about the multiple procedure methodology. Instead of 150-25, or we can go to 150-50-50-50, or something like that. The list of questions you can ask a payer is actually pretty extensive if the message is, we can't go any more on groups 1 through 9. And as a negotiator, my job, or if you're representing yourself, your job is to try to identify those opportunities and try to ask those questions to get the payer to open up on where opportunities may lie that you haven't already touched on.
Got it. Anything you wanted to add, Angela?
No, I think Matt covered it excellently.
Perfect. All right, this next question here is, how often do you see outside vendors being used? Matt, what do you think there?
Well, I guess the question around outside vendors for say implants is, we're used to be a little bit more frequent when there were 2, and with the demise of Access MediQuip, we're left with IPG. But I see that growing in its utilization. IPG's services growing in their utilization, and commercial payers are starting to utilize their services quite a bit more. In terms of outside vendors for other things, I guess I'm interpreting what the question was from the audience, but you know, there's still a robust business for consulting services or for support in things like RCM or contract negotiation or you know, quality measurements, things of that nature. Let me pause there, and I'll ask Angela to add her thoughts.
Yeah, I think outside vendors, so that outside vendor can mean two things. An outside vendor as far as, you know, ECG or surgical notes as an RCM to assist in the contract negotiations, or the vendor could also be IPG. And IPG I do see coming up and being more frequently used. Back in the day when there were two, IPG was pretty much solely locked in with Cigna. Now I see a lot of the top payers utilizing it. Again, it depends on what market you are in, what state, but I am seeing it coming up more and more frequently. And I think it's an excellent source for centers to pursue in their contracts when they can utilize IPG and not be out of pocket for those implants.
Got it. Well, it looks like those are all the questions for today, but of course, if you think of any more after we end the webinar, please feel free to email those over to me, and I'll be sure to check in with Matt and Angela to get you your answer. Thank you all again for joining us, and thank you, of course, to Matt and Angela and Chuck for providing the webinar. Just as a reminder, I will be emailing out the slides and the recording to everyone before the end of the week for you to watch later or share with any of your colleagues that weren't able to join us today. Thank you and have a great day.
Thank you.
Thank you.
Thank you.